We already know that prostate cancer is very common in older men. We also know that almost 1 in 2 men with prostate cancer get put on androgen deprivation therapy or hormonal therapy, as it's commonly known. And there are a number of side effects of androgen deprivation therapy in men, particularly in older men. It can lead to reduced quality of life, increased fatigue, reduced muscle mass, and a number of metabolic consequences such as osteoporosis and diabetes. The single most effective treatment to prevent or treat the majority of these complications of androgen deprivation therapy is exercise. And there are now over a dozen clinical trials of various durations, anywhere from 8 to 24 weeks, that have shown that you can improve quality of life, you can reduce fatigue, you can improve muscle mass, you can improve strength, you may even be able to improve bone density and reduce diabetes, all with this one intervention. If it were a pill, it'd be so easy to prescribe. But exercise is not that easy to prescribe, and there are a couple of remaining challenges in the world of exercise science. 3 of them, in our view, are that we don't know what type of exercise works best. And what I mean by that is not aerobic versus resistance exercise, because we know that both aerobic exercise when you're working on the treadmill or jogging and resistance exercise with weights, they both have some advantages. And so that it's not one versus the other, we really need both. It's more the issue of how do you deliver the exercise. And so that the best method of delivery from the trials has been supervised, in-center, one-to-one personal training. The problem is that's not very feasible, it's resource intensive, most men don't go to a center, and virtually no government pays for a program like that. And so the question is, can we find less resource intensive exercise delivery methods, such as group supervised programs or home-based or other approaches that are cheaper and more scalable, but just as effective? And do we actually know the cost effectiveness of these programs? Can we formally evaluate it? And third, once you stop the formal program, let's say you're in a period of supervision and then you're on your own, can people continue to have long-term adherence? Because like in anything else with exercise, if you stop doing it, you lose the benefits. And so we designed a phase 2 randomized control trial that looked at 3 different methods of exercise delivery. Our gold standard was the supervised one-to-one personal training. We compared that with a group supervised program, and we compared that with a home-based program that was unsupervised but supported remotely by smartphones and health coaches. And the phase 2 trial was a non-inferiority study where we were seeing if either the group-based or the home-based program were non-inferior to the gold standard. And because it was a phase 2, it was not meant to be definitive, but rather make sure that these 2 programs were not profoundly worse or potentially better, so that we could go forward with a larger trial. What we found was that, first of all, conducting the trial was feasible, although it took longer to recruit than we were hoping, but that in most of the comparisons between group-based and the gold standard, as well as between home-based and the gold standard, on measures of quality of life and physical fitness, the different modalities were similar. And what that suggests to us is that going forward, we should be able to design a multi-center phase 3 randomized trial to test these definitively. And we need to look at cost effectiveness, but it's feasible, and both of those approaches seem, at least in the phase 2, not to be significantly worse than the gold standard, and so there are opportunities to study them more formally. That's, in essence, what we found.